Hello, this is Dan Kelly. This video web presentation is for Adult and Geriatric Nursing 5602. The subject of this clinical presentation is a 53-year-old female who, the day prior to coming to the emergency room, reported having some small red blotches on her arm. The patient thought nothing of it, went to bed, and in the morning awoke having her arm very red, very painful, and swollen. She arrived to the emergency room. Her arm was erythematous from the wrist all the way up to the upper breast. Her um, her description of the pain was sharp, 10 out of 10, constant. She stated that having her arm supported did help with the pain, and there was nothing that she tried that did relieve it. She had tried Motrin, she had tried ibuprofen, as well as a Norco she had from a prior incident. The patient also reported that she had had cellulitis to that same extremity 3 times. The patient said that her current condition mimicked that of her 3 previous cellulitis, and that's what she thought she had. She also went on to report that on all 3 occasions she ended up having to have a PICC line and had long-term antibiotic therapy on an outpatient basis. The patient also reported associated symptoms of fever, chills, nausea, and headache. Denied chest pain, abdominal pain, shortness of breath, along with diarrhea. Along with the patient's breast cancer and lymphedema, the patient also had previous surgeries of lymph biopsy and LASIK surgeries, as well as a hysterectomy. Patient's family history included her mother with diabetes, father had hypertension, grandmother and grandfather both had heart attacks on her mother's side, and her paternal grandparents, the grandmother had a stroke and the grandfather had diabetes, a PE, and an MI. All family members are still living. Patient's allergies include aspirin, which causes nosebleeds, cefepime, which causes hives, penicillin, also causing hives, and vancomycin, causing anaphylaxis. The patient was never a smoker, does not use smokeless tobacco, drinks alcohol daily, 2 glasses of hard liquor, denies drug use, and is sexually active with male partners, exclusively her husband. The patient is an independent, living woman who lives in the Woodlands, Texas, with her daughter and her husband. She needs no assistance with her ADLs. She owns her own home and business, and does not have any socioeconomic issues. Her review of systems, constitutionally she has positive for fever and chills. Skin redness to the right upper extremity all the way to the right upper breast, which was warm to the touch. She denied any shortness of breath, chest pain, or palpitations. She denied any pain or cough. Denied any changes in appetite or weight loss, unexpectedly or intentional. She did complain of nausea, no abdominal pain, no diarrhea, no constipation. She reported no changes in strength, no joint pains, no arthralgias. She did complain of headache, denied any memory changes or weakness, no changes in mood, denies any new bruising or recent infections. Her blood pressure at the time was 137/66, her pulse was 95, temperature was 108, oral, respirations at 16, her sats were 100%. She was in no distress, she did not look toxic, she was normal cephalic and atraumatic. Sclera was enteric, pupils were equal. Mucous membranes were pink and moist, no lesions or exudates noted. There was no jugular distension, no stridor, Her heart rate was regular, no murmurs, no rubs, no gallops. She had no pedal edema, although edema was noted in the right upper arm. No chest pain, good effort, good equal expansion, regular respirations, and good rate of 16. Lungs were clear bilaterally, no crackles, wheezes, or bronchi. Her abdomen was soft, non-tender, active bowel sounds. Extremities had no clubbing, no wasting, no weakness. Radial pulses were equally bilateral. Sensation was intact. Skin was warm and dry. There was redness noted to the right upper arm from the wrist to the right breast, and the arm was hot to the touch. There was no cyanosis noted, no diaphoresis, and mentation was intact. She was awake, alert, oriented, clear speech, and good memory. The patient was cooperative and had a normal affect. Labs that we did were a CBC, a CMP, a lactic acid. We did blood cultures and a right arm ultrasound. Significant lab findings were her white count was 19.2. Her lactic acid was within normal range. The ultrasound to the right arm, was negative for DVT, and there were no other significant lab findings for this case. The differential diagnosis we came up with were right arm cellulitis, right arm DVT, and lymphedema. The assessment and plan of care for this lady was admit to the med-surg floor for right arm cellulitis. We're going to admit her with IV antibiotics. Her lactic acid in the ED was negative. We started her on clindamycin in the emergency room. We are pending blood culture results. We contacted and consulted infectious disease who came to see the patient in the emergency room. We also contacted and consulted RR for long-term PICC placement and long-term antibiotics. Case management is also involved to arrange that on an outpatient basis for when the patient leaves the hospital. The ultrasound was negative, so we ruled out DVT. The patient was given Dilaudid for pain control, and we ordered a CBC and a CMP in the AM to trend the leukocytosis. Because the patient is still being treated for her breast cancer, we are continuing her tamoxifen, and we are putting her on Lovenox and SCDs for her time in the hospital to prevent DVT. The key points for this case was when she mentioned the 3 previous episodes of cellulitis that mimicked the symptoms she was having today. That was one, listening to the patient and letting her sort of guide where we were going with this. She did say that, like I said, she felt that this was another cellulitis episode, and it was. The patient was having constitutional symptoms such as fever and chills, and that does require hospitalization and IV antibiotics. That was key point number 2. Although we felt that the likelihood of a DVT was low due to the redness and the fever, the must not misdiagnosis, and that is why we ordered the ultrasound to make sure that it was not a DVT. The 5th point that we tried to go over was she did have a history of breast cancer and lymphedema to the right arm. However, the patient did say that after her reconstructive surgery, they were able to correct that, and since 2013, that was no longer an issue. So the likelihood of her having lymphedema in that arm was low. So the patient was admitted to the med-surg floor for IV antibiotics. She was discharged 2 days later and is now currently receiving in-home antibiotics and has followed up on an outpatient basis with the infectious disease doctor.